to research gastric tumors. Specifically, I chose to learn more about leiomyomas and gastrointestinal stromal tumors, which are commonly just referred to as GIST. I'd like to begin by sharing a little background story. About 5 years ago, I woke up with uncomfortable tenderness in my upper abdomen. It kind of felt like I had done a crazy ab workout the day before, but I hadn't. And I thought it would go away, but after a couple days, it was still there, and it got so bad that I couldn't fully stand upright without pain. So I called my primary doctor, and she told me to go to the ER because that's where they could do diagnostic tests. That night was kind of a blur, but I had blood tests, an x-ray, a transabdominal ultrasound, as well as a CT scan. There's a picture that I sent to my dad to let him know I was fine. I would just be home later than usual. I was referred to a surgical oncologist, and I saw him the next day. He told me that based off of my test the night before, he believed I had a rare but favorable form of pancreatic cancer. He scheduled for me to have a endoscopic ultrasound-guided fine needle aspiration biopsy. Basically, they put a tube with a camera and then a fine needle down your mouth and esophagus into the stomach, and they're able to take a tissue sample from there as well as visualize the tumor. And the results of that biopsy came back consistent with what my oncologist thought that I had, so I had surgery a week later. Fast forward to when I woke up from the surgery, I was told that I had made everyone in the operating room's day, because it turns out that that my tumor wasn't actually on my pancreas, it was on my stomach. So that was great, and that recovery would probably be a lot easier than what we had anticipated. But the downside was that then we didn't know what my tumor actually was. So my doctor told me that he thought it was probably a GIST with malignant potential, but further tests would need to confirm that. I spent 8 days in the hospital, and eventually I did get the results that my tumor was a benign gastric leiomyoma. So that was great. I did have follow-up CT scans and upper endoscopies both 6 months and 1 year later, and I was told I don't need additional follow-up care as long as I don't develop symptoms again. That was a pretty scary and uncertain time in my life, but now I really have learned to truly appreciate good health. So by the time I received that final diagnosis, I was exhausted with the process. I normally am someone who would do a ton of Googling about the topic, but I just didn't have the energy, and I had to catch up from the work I missed while I was out recovering. So when Jody introduced this presentation, I was eager to have an opportunity to research such a personally significant pathology. Okay, so in this presentation, we're going to first quickly review a bit about stomach structure. Then I'm going to provide a general overview of different types of gastric tumors. Next, I'll focus in on leiomyomas and gastrointestinal stromal tumors, or GIST. We'll talk about their mixed diagnosis history, some characteristics, some imaging modalities, treatments, as well as prognosis. And at the end, we will recap what we learned today. Okay, so first, recall that there's different names for different regions of the stomach, like the cardia up here in the proximal region, and the pylorus down here in the distal stomach. Also recall that the stomach wall is a layered structure. So the innermost layer abutting the lumen is the mucosa. It contains those gastric pits and glands where different enzymes, stomach acid, and the protective mucus is produced. Next, underneath that is the submucosa. Beneath that is the muscularis, and the stomach differs from other parts of the GI tract because it has an additional layer, the oblique muscle layer, in addition to the circular and longitudinal layers, and that really allows for that churning motion of the stomach. And then the final outer layer is the serosa, which is the lining that wraps around the outside of the stomach. The cells produce serous fluid, and the layer is actually continuous with the parietal peritoneum, like we learned about earlier this semester. In this picture taken during an endoscopic ultrasound, you can actually see the layers of the stomach wall, and I think that looks pretty cool. We can see that the different layers of the stomach wall have varying levels of echogenicity. From my understanding, the center of that picture is the transducer, and then there's generally going to be some sort of water balloon or something like that around the transducer to help get good pictures. Okay, so why is this important information? It's important because every layer has the potential to produce a tumorous growth, and in the case of cancerous growth, these layers are going to be important in determining the stage of cancer, which can really affect a patient's treatment options and prognosis. And lastly, location of the tumor is just kind of like another puzzle piece or clue as to what that tumor might be, whether that's the general region of the stomach it's found in or the layer from which it originates. So speaking of classification, my first Google searches for gastric tumor were kind of overwhelming, to be honest. I quickly learned that there's a lot of interchangeable vocab, which isn't really new. We're already used to that in cross-sectional anatomy. So for example, the black slide here says neoplasms of the stomach. That's just a synonym for tumor. Mass, lesion are also words that can be used. You can see that they break up the benign category a little differently. One slide says polyps and tumors, another says epithelial and mesenchymal, and even the malignant category is presented a little differently on each slide. One slide has a potentially malignant category, and the types that they choose to call out are a little different on each one. And these lists only scratch the surface, so the theme of it's kind of complicated will be carried throughout today's presentation. But that makes sense though, right? Tumors are just an abnormal mass of tissue that is a result of abnormal cell division, and naturally occurring events don't always fit into neat, perfect little categories. So for our purposes, we can think of really two different big overarching classification categories. A tumor can be classified by its severity, whether it's benign, meaning non-cancerous, doesn't spread, or malignant, meaning cancerous, can or does spread. And of course, there's a middle ground in there to make it more complicated of potentially malignant. And a tumor can also be classified by its cell or tissue of origin. Most gastric tumors are epithelial, meaning that they arise from the top or innermost mucosal layer. An example of that would be hyperplastic polyps, which are benign, or gastric adenocarcinoma, which is actually the most common type of stomach cancer. The tumors I chose to research more in depth are classified as non-epithelial or submucosal tumors, meaning that they arise from the layers that are deep to the mucosa. And of course, there's many other tumors in that category too, like lipomas or schwannomas that we're not going to talk about today. So I initially intended to gather information about gastric leiomyomas only, since that's ultimately what I had, but I quickly found out that GIST and leiomyomas are just intertwined, and they share a lot of shared features. In fact, a lot of the papers I would find for leiomyomas were actually papers about GIST that just briefly mentioned leiomyomas. In fact, I learned that most non-epithelial gastric tumors are uncommon or even rare and have overlapping features, so it can be pretty difficult to accurately classify a gastric tumor in general. For example, the diagram you see on this slide shows the differential diagnosis of GIST, which essentially just means that all of these other tumor types could potentially cause some similar symptoms and share some overlapping characteristics with GIST. These all must be ruled out by examining a lot of different characteristics of the tumor in question. So it turns out that currently, in the stomach at least, GIST far outnumber leiomyomas. But this wasn't always the case. One current estimate from a study says that there are only 4 gastric leiomyomas reported for every 100 GIST. However, in the past, GIST were often misclassified as leiomyomas or a few other similar types, so they were thought to be relatively uncommon in the stomach at least. However, in 1998, it was discovered that most GIST cells contain a mutation for the KIT gene, which causes activation of a protein called KIT, which ultimately causes faster cell growth and division. This genetic and protein difference, along with some others, allows pathologists to classify a tumor as a GIST. But of course, to keep it complicated, an estimated 5% of GIST don't actually express that particular protein, so there has to be other methods to distinguish a GIST. But it's important to correctly classify a patient's tumor because the risks and potential treatment options vary depending on the diagnosis. For example, some tumors maybe can just be monitored if they're small and not causing any symptoms and thought to be benign, and others may need to be treated really swiftly with both surgery and other types of therapy. Okay, so without further ado, let's dive in and specifically talk about GIST and leiomyomas a bit more. So gastric leiomyomas are benign mesenchymal neoplasms that are now considered very rare in the stomach. One resource I found estimated that there's fewer than 3 cases per million people, but statistics really seem to vary from paper to paper. In the stomach, they're most commonly found in the proximal cardia region, but they also can be seen in the body or antrum or honestly anywhere else. Those are just the most common places. They arise from the smooth muscular layers, and usually this means they're arising from the circular or longitudinal layers, but they also can sometimes arise from that thin extra layer of smooth muscle you see in the image that's actually sitting atop the mucosa. Like I said, it's a bit complicated. I anticipate that we're going to be learning about leiomyomas in future classes because although they're rare in the stomach, they're actually pretty common in other places of the body, and they can be found anywhere where smooth muscle is found. So they can be found in other places of the GI tract, like the esophagus and the colon. They can be found in the skin, the eyes, the bladder, as well as the uterus. And it seems like they're quite common, and they're generally referred to as uterine fibroids in that area. Now, GISTs are actually the most common subepithelial tumor, with an estimated 15 cases per million people. But this estimate again varies. And it's important to note that although I'm saying it's the most common subepithelial tumor, it's still really rare in the big picture. It's just a little less rare than the other tumors in that category. Most cancers are epithelial carcinomas. A GIST is considered a type of sarcoma, which together that whole category represents about 1% of adult cancers. So again, still pretty rare. And recall that GIST stands for gastrointestinal stromal tumor. So of course they can occur all along the GI tract, but the stomach is its most common location. They are hard to distinguish from smooth muscle tumors like leiomyoma, but they actually arise from cells between the muscle layers called the interstitial cells of Cajal, or sometimes abbreviated ICC. And these cells mediate communication between the autonomic nervous system and the smooth muscle. And sometimes they're called the pacemaker cells of the gut, and that's because they help send signals that trigger contractions that are going to propel material through the GI tract, and we call that peristalsis. And as I said before, they are most commonly caused by a mutation in the KIT gene. GIST have a somewhat unpredictable evolution, so classifying them as malignant, benign, or potentially malignant appears to be a little bit of a debate from the research I did. Some resources even contend that the word benign should never be used for GIST and that low malignant potential should be used instead. These classifications are generally based on size, location, and mitotic index, which is just a way to quantify the rate of cell division. So how are gastric tumors like gastric leiomyomas and GIST discovered in the first place? I found a list of potential symptoms, and they were pretty similar for both types. So symptoms can really depend on the tumor size and location, and potentially patients may have general abdominal discomfort or pain. With that can come decreased appetite, discomfort while eating, weight loss, fatigue is also common. And larger tumors are even more prone to associated ulceration, and therefore they might cause bleeding, and you might have symptoms that are related to bleeding, like blood in the vomit or the stool, or even anemia. However, more commonly, gastric tumors are asymptomatic, especially when the tumors are really small. And many gastric tumors are found incidentally, meaning by chance, when medical imaging or surgery is done for some other unrelated reason. The diagnosis process first involves a variety of imaging tests, but the exact combination varies from patient to patient. And sometimes part of the troubleshooting process involves other tests like standard x-rays and trans-abdominal ultrasounds like I had. And taking a look at the tumor from inside the GI tract can be done via endoscopy, which is just like a camera, and endoscopic ultrasound, which we saw earlier when we reviewed the layers of the stomach wall. And CT is almost always used. It produces those really nice detailed cross-sectional images of the body. And generally enough information is obtained from those imaging tests, but sometimes, especially with a suspected or confirmed malignant GIST, MRI and PET scans can also be used, and those can help determine the extent or the spread of the cancer. PET can also be helpful in finding out if drug treatment is working, and that's because if the drug is working, the tumor should no longer be taking up the radioactive sugary substance that's injected into the patient. And these imaging tests can help narrow down the potential diagnoses, but an official diagnosis can only be determined after a tissue sample has been examined by a pathologist. Now, this tissue sample can be obtained via an endoscopic biopsy, and there's a few ways that can look. There can be little forceps that pinch off a sample, or there can be a thin hollow needle, like what I had to remove a small sample. And these biopsies aren't always done if it's deemed too risky. Sometimes biopsies from small samples aren't fully reliable because there might not be enough of a sample. Other times the sample that's taken might not be representative of the entire tumor. So generally, if a tumor is surgically removed, it will also be examined after it's resected. So tissue samples are evaluated by a pathologist who look at the appearance, the shape, the features of the tumor cells under the microscope. And different stains, called immunohistochemical stains, can be used on the samples. And those are basically just tests that use antibodies to detect the presence or absence of different proteins in the cells. And the idea is that different tumor types are more likely to express different kinds of proteins. A couple examples here: GIST tests positive for the KIT protein, which I've already mentioned, as well as a protein called DOG1 that can sometimes be overexpressed in GIST. And leiomyomas test positive for desmin, which is a protein specific to a smooth muscle. Okay, here I have some example pictures of leiomyoma taken through various imaging modalities. Box A there is showing an axial CT that's been enhanced with contrast. B is showing endoscopic ultrasound image. C is showing the histological appearance of those cells, and D is an endoscopy image showing smooth overlying mucosa. And there's different features. You can see that it says that in the ultrasound image that it's hypoechoic solid leiomyoma, but that's not always consistent across the board. Here are some example pictures of GIST. And again, we have a CT, an endoscopic ultrasound, a histological evaluation, and an endoscopy image. And you might notice that that endoscopy image looks awfully similar to the leiomyoma endoscopy image on the previous slide, which is why you can't just look at a tumor and know what it is right away. You have to really combine all these different puzzle pieces to get a better idea of what it possibly could be. And again, this slide here is calling out some different specific features. So in the contrast image, it's around homogeneous low density GIST, but again, that's not uniform across the board. Something else about GIST diagnosis is just really how tricky it can be as a whole. I like this diagram because it demonstrates kind of the different things that have to be looked at and the wide range of clinical and imaging appearances that can exist in regards to patterns of enhancement, their location in the body, and their location in the wall of the stomach in this case, as well as the presence or absence of other features like calcification or necrosis. And one thing that sets GIST diagnosis apart from a benign leiomyoma is that there's various staging systems that are used to describe the extent and severity of the cancer. The TNM staging system that I have here is just one of the ways to do it. It's based off a few key pieces of info like the size of the tumor, whether it has spread to lymph nodes and other parts of the body, as well as the mitotic rate, which can be described as high or low. And then how these different pieces of information are combined is kind of complex, but ultimately you could get a stage number, which really indicates the severity. So how are they treated? Treatment is going to depend on its size, its location, its growth pattern, meaning does it grow into the lumen or is it kind of more hanging on the outside, as well as if it has spread to other parts of the body. Treatment plans are really decided on an individual basis between a patient and their doctor. Small benign leiomyomas might be able to just be monitored for growth, but if a tumor is over 3 centimeters, is causing symptoms, or if it really can't be determined if it has malignant potential, it's generally advised to be surgically resected. For GIST, resection is almost always recommended, but sometimes total resection isn't possible. For larger tumors, open surgery called laparotomy may be required, but when possible, it makes sense that it's more favorable to do minimally invasive laparoscopic techniques. Laparoscopy involves little or multiple incisions on the abdominal wall, and then a thin lighted camera called the laparoscope is inserted into one of those incisions along with other instruments. This is the type of surgery I had, so if you practice scanning on me, you'll get to see my 4 little scars from my laparoscopic surgery. 2 examples of approaches or techniques would be laparoscopic wedge resection, which involves removing a wedge of stomach tissue that contains the origin of the tumor, and a stapler is used to cut out and rejoin the edges. You can see that there in the image. Enucleation is another possibility for really small tumors, which carefully removes the mass while leaving the surrounding tissues intact. And I saw an analogy somewhere that it's like cleanly removing a nut from a shell. Like I mentioned on the previous slide, GIST may not always be able to be surgically removed if they've spread. Also, sometimes a tumor is really large and it would be helpful if it was shrunk down a little bit before it was removed. Well, thanks to the revolutionary drug imatinib, I think is how you pronounce it, a target drug therapy for GIST does exist, and it wasn't always the case. It was approved by the FDA in 2001, so really we're looking at about 20 years that this has been used. And this is great because previous attempts to use traditional chemotherapy weren't very effective. Imatinib is a type of TKI, which stands for tyrosine kinase inhibitor, and it targets the KIT protein I've mentioned, which is a type of tyrosine kinase. And this helps to block the tumor cell's ability to grow and divide. And this is really a specific targeted drug, which means that generally the side effects are going to be mild to moderate, which is really good. And there's other types of TKIs in the event that a patient stops responding to imatinib. So what's the prognosis for patients with gastric tumors? Well, of course, it's going to depend on the diagnosis. Prognosis for leiomyomas is excellent. In fact, it's so good that I couldn't find a really solid statistic, but I only really found articles mentioning really rare complication case studies, but for the most part, prognosis is great. For GIST, on the other hand, the average 5-year survival rate is 83%, and that really is an average. Of course, that's going to depend on the size and the spread of the tumor. And there's also different rates of reoccurrences of tumors depending on the size of the tumor and whether it had a low or high mitotic index. And of course, that's going to vary across the board. For either tumor type, but especially for patients who had GIST, regular follow-up care with your doctor is important. Any new symptoms should be reported, and some patients require additional follow-up testing, and that's really up to the patient and the doctor to determine how long-term that's going to be, but that can involve endoscopies, that can involve further imaging, CT, MRI. It really just depends. So, just to quickly recap, as my personal experience showed that I shared with you, it can be really tricky to formulate an exact diagnosis when a patient is experiencing really generalized symptoms like abdominal pain. Other patients with gastric tumors may not even be experiencing symptoms, and the mass is found incidentally. As this table from an academic paper shows, although there's patterns, there's not always obvious, unique defining characteristics. And doctors treating patients with gastric tumors must consider the big picture, including the patient's history, physical symptoms, imaging findings, and usually, more importantly, histological findings. So thanks so much for listening to my presentation. Here are my resources. I hope you learned something.